Hello, and welcome to our case presentation on newborn hypoglycemia, presented by Chantal and Corrie and myself, Corrie Secord. Let's begin. JH is a 37-year-old Gravida 3 P2002 who presents to the OB/ED at 39 and 2 weeks, dated by Ellen 8, with complaints of regular contractions for 3 hours. Her OB history is complicated by advanced maternal age, A1-GDM, and a BMI of 36. She's GBS negative, rubella immune, her blood type is A positive. OB history is significant for 2 vaginal births of large for gestational age infants, gestational diabetes with both pregnancies, which resolved by 6 weeks postpartum, and her last delivery resulting in a 3rd-degree tear. Her medical, surgery, social, and family history are unremarkable. In triage, she has a reactive non-stress test. Her cervical exam is 690 -1 station. Baby is vertex by bedside ultrasound. Leopold's maneuver shows an estimated fetal weight of 4,000 grams. She is breathing with contractions and is admitted for labor at term for an anticipated vaginal birth. She was diagnosed with A1-GDM in the first trimester. According to ACOG Practice Bulletin 190, a pregnant woman with a BMI greater than 25 and a history of gestational diabetes should receive early prenatal glucose testing. A point-of-care test is taken upon admission, and her blood glucose is 90, so we will recheck her sugar in 2 to 4 hours or if she feels symptomatic. A 2019 randomized control trial by Hamel et al. Compared the effects of tight glucose control with liberal glucose management in laboring women. The study found glucose between 60 and 120 milligrams per deciliter, combined with a reduction in glucose screening in labor, resulting in better newborn glucose outcomes the first 24 hours of life. This study promotes liberal management and upper thresholds for maternal blood glucose while laboring. 2 hours after her admission, her bag of water is ruptures with clear fluid and is accompanied by the urge to push. With good maternal effort and guided pushing, she births vigorous newborn boy in hands and knees position, resulting in an intact labia, vagina, and perineum. After delayed cord clamping, her baby boy is placed on her chest and skin to skin. At 30 minutes of life, he latches to her breast and nurses for 30 minutes. APGARs were 9 and 9, QBL is 200, and she names her new baby Jake. At 1 hour after feeding, the RN comes in for a newborn assessment. After asking for permission from the mother, baby Jake is taken to the warmer. His exam is normal, and he weighs 3,945 grams. The RN plots out his weight and shows the size is large for gestational age. According to the American Academy of Pediatrics, large for gestational age is defined as birth weight above the 90th percentile. Hypoglycemia risk factors for this newborn include LGA size and being born to a diabetic mother. JH is informed of these risk factors and the recommendations for glucose screening in the newborn. She verbalizes understanding and is agreeable, and the nurse applies a warm pack to baby Jake's heel and prepares the glucometer for point-of-care testing. Newborns commonly have acrocyanosis due to poor circulation to the hands and feet. While this is normal, it is best practice to apply a heel warmer to the newborn's foot prior to testing to increase pedal circulation. Baby Jake's blood sugar is 39, which is low. However, he is alert, has good tone, his temperature is normal, and he's not jittery. The midwife encourages JH to breastfeed baby Jake again. He latches deeply and nurses on each side for 15 minutes. An hour after feeding, his blood glucose is checked again, and it is now 37. He is still asymptomatic, but it's now time to intervene to help stabilize his blood sugar and avoid a transfer to the NICU. The diagnosis for this newborn is neonatal hypoglycemia. According to Danny and Corsini 2020, hypoglycemia occurs in roughly 10% of healthy term infants, typically during the first 24 to 48 hours of life. Transient neonatal low glucose levels are not uncommon right after birth. It's therefore important to differentiate between physiologic and pathologic hypoglycemia. The AAP recommends at-risk newborns maintain blood glucose in the first 4 hours of life above 40, and from hours 4 to 24, maintain those levels above 45. The AAP clinical guidelines on neonatal hypoglycemia state that any approach to management needs to account for the overall metabolic and physiologic status of the infant and should not unnecessarily disrupt the mother-infant relationship and breastfeeding. Older interventions for low blood sugar typically involved an IV infusion of dextrose, which required an invasive procedure, causing stress to both mother and baby. A more recent intervention is the use of dextrose gel. ELISA 2021 promotes the use of dextrose gel as a safe, inexpensive, and non-invasive way to treat hypoglycemia without separating mother and child. Additionally, A 2016 Cochrane review by Weston et al. Found that newborns who were treated with dextrose gel instead of IV glucose were more likely to be breastfed at the time of discharge. After a quick consultation with a newborn nurse practitioner on call, the midwife orders 1 dose of 40% dextrose gel, and the nurse immediately administers this to baby Jake. Half of the dose is administered into each buccal mucosa. Once more, the midwife asks Jessica, JH, to breastfeed. This time, she requests a one-time formula supplement to add volume to baby Jake's intake. This is, of course, an acceptable request, but before using formula for an infant born to a mother who had expressed the desire to exclusively breastfeed, the midwife asks why she prefers formula for this feeding. In turn, JH expresses her concern about knowing how much volume she is giving her newborn. She's then offered assistance with hand expression so she can visualize the amount of colostrum baby will get. She declines and expresses preference for formula for the feeding once again. Wanting to fully educate her for her informed decision-making, the midwife asks if she would prefer donor milk to formula. Patient responds with concerns about the COVID-19 virus in donor milk and isn't sure that's a good option for her. A 2020 study by Chantal et al. Tested the efficacy of the Holder pasteurization process on human milk spiked with the COVID-19 virus. Although the sample size was small, the study found that the pasteurization process completely eliminated the SARS-CoV-19 virus in all affected samples. After sharing this data with JH, she opts for donor milk. Baby eagerly drinks 10 mLs of donor milk. His 1-hour post-feed point-of-care test shows a blood glucose of 46. Now that he has shown stabilization, the next time we'll check his blood sugars before his next feeding, or sooner if he displays symptoms. Mother is encouraged to put him to breast in 2 hours and to call out beforehand for point-of-care testing. She's also relieved that her baby has responded favorably to dextrose gel and to the donor milk. She asks when she should have his newborn bath done. So we inform her that it's best to wait for 24 hours to bathe the baby to establish euglycemia. A 2019 Chamberlain et al. Study concluded that delaying the newborn bath for a full 24 hours has a positive effect on newborn temperature stability and blood glucose control, which in turn results in fewer heel sticks for glucose testing. She's very glad to hear this news and opts to wait for the full 24 hours. The rest of their stay is unremarkable. Baby Jake has 3 pre-feed blood sugars that are greater than 45 milligrams per deciliter. He does not require any more supplementation. Mother and baby are discharged home on postpartum day 2. They do follow up 2 days later, which is also unremarkable. JH reports her baby is nursing on demand at least 8 times in 24 hours, and her milk has come in. Before leaving the follow-up visit, the midwife reminds her to return to a clinic visit at 6 weeks for her checkup, and she gives her the instructions for completing a 2-hour 75-gram glucose test for that clinic visit. Now, let's discuss why we are concerned with screening at-risk newborns for hypoglycemia. At birth, a newborn's brain accounts for about 25% of its body weight, but consumes 90% of total glucose taken in. When glucose reserves are depleted, there's a physiologic disturbance resulting in a stress response. In an attempt to normalize the metabolic process, there's a release of catecholamines and glucagon, with subsequent lipolysis and glycogenolysis in an attempt to increase substrate availability. This depletion of endogenous substrates leaves the infants with a diminished capacity to endure any stress, and further stress may result in brain injury or insult, regardless of the presence or absence of symptoms. Severe post-birth hypoglycemia can cause respiratory depression, and if left unnoticed and untreated, it can lead to apnea. This can cause significant long-term developmental effects in at-risk newborns. A 2019 study by Narvi and Mark showed as few as 6 episodes of hypoglycemia were associated with a smaller head circumference at 12 months, 18 months, and 5 years of life, and psychometric testing showed impairments at 3.5 years of life. Transitional neonatal hypoglycemia can be corrected through breastfeeding, formula feeding, and buccal dextrose. In more extreme cases where at-risk infants are asymptomatic, IV dextrose and transfer to NICU might be necessary. According to McDonough et al. 2020, universal screening for the healthy term newborn is not necessary, but it is important to screen at-risk infants to avoid neonatal morbidity, mortality, and long-term sequelae. In summary, this case discussed newborn hypoglycemia risk factors, symptoms, screening, early diagnosis and interventions, and the pathophysiology for low blood sugar in the neonate. Evidence-based practices in this case include the early glucose test for mother, universal GBS screening, liberal glucose management in labor, delayed cord clamping, the golden hour, using a heel warmer prior to point-of-care testing, early diagnosis of hypoglycemia, dextrose gel, the safety of using donor milk in the COVID-19 pandemic era, and delayed bathing. The case study reviewed safe care for the at-risk newborn experiencing hypoglycemia. Using current AAP screening guidelines, care focused on preventative screening and early diagnosis and treatment of hypoglycemia to avoid sequelae. Universal care components included early glucose tolerance testing for mothers at risk. Universal care components included early glucose tolerance tests for mothers at risk for GDM, universal GBS testing, screening the at-risk newborn for hypoglycemia, and help provide safe and thorough care. Individualized patient-centered care for this mother-baby dyad included delayed cord clamping, skin-to-skin contact, the golden hour, asking permission to assess the baby, avoiding separation by using glucose gel instead of IV dextrose, discussing feeding options for the mother who prefers breastfeeding, and delaying the newborn bath to promote euglycemia. Positive health behaviors taught and used that impacted the family and health behaviors are encouraging skin-to-skin, the golden hour, encouraging breastfeeding, asking permission, having a 2-day follow-up, and promoting a 6-week postpartum follow-up with a 2-hour glucose screening for mother. Chantal Danga and I both equally contributed to this contributions are by Chantal and I. I created the case scenario and presented, and both of us wrote the script, conducted an in-depth literature review, and contributed to the evidence-based case scenario. Attached you will find our references. Thank you for joining us today.